the overview of this lecture is for us to look at new research so that we can relate that to dance practice internationally. So one of the things that we know is that pain is viewed differently in different cultures, but we do want to start looking at the advances that have been made. So a lot of Western culture was held in a position that, to my mind, it's almost like we've been treading water. So at the turn of the century, as we went into 1901, there was a decision made that if you were going into medical practice, you had to choose. You were either going to concentrate on the physical body or you were going to concentrate on the mind. And somehow that changed into, if you chose to look at the mind, you were somehow somewhat lesser than the people who'd chosen to look at the physical structure of the body. And I guess what all of us attending this lecture today understand, even though we may not have as much evidence as we would like, that the body and the mind work together. And so that's an area that we've really been digging into to try and come up with evidence that actually supports that notion. It's common sense, we kind of know it, but how is it that within medical practice there is an assumption by some particular areas of medicine and some particular individuals that the mind and body isn't working together? And we will have all come across a medical practitioner who finds it quite difficult to relate to people and actually to talk to them about what's going on, but they're excellent at dealing with a particular physical condition. So there's a lot of mixed messages which I hope we start to clear up in this lecture. So we want to look at pain in a slightly different way. So the first thing we need to understand is that chronic pain is different to acute pain. So chronic pain is a little bit confusing because often people refer to chronic pain as if it's very bad pain. And that is a true interpretation of chronic pain. But the way I want us to view chronic pain in this lecture is that it's pain that's been in the body for over 3 months, and that's very important. The over 3 months means that the brain is sending the pain, and the pain has shifted from emanating from the particular site in the body. Whereas acute pain, that means it's immediate, it's an injury. You cut your finger or you got out of the car and you hurt your back. Then you mind your back for a day or two and your back then reverts to normal. There's no more pain. But if the pain lingers and it continues, and 6 months on, you've still got that back pain from getting out of the car in that particular way, then we need to look at the pain differently. It's the brain sending a signal, and the self-healing hormones within the body are not responding and healing as we would hope they would do. There's always room for intervention. If you were to hurt your back and have acute pain, there would be medical practitioners that it would be wise to go to, and they would treat that immediate pain. It is different when that pain has then been there for longer than 3 months. And we're going to come back to that in a short while. So dancers often present with chronic symptoms for which there is no clear medical explanation. That includes pain. They also might have anxiety, depression, fatigue, and insomnia. And those are the areas that we're looking at today in a different way, so that we're looking at how the brain plays a part in those symptoms if they've been around for over 6 months or 3 months, up to 6 months. And for us to understand that, we need to understand the neural pathways. They can help and they can impede healing. And that's all to do with the autonomic nervous system. So if we go down To make that clearer, key research is about the clinical concepts that underline resolving chronic pain approach. We've got the old paradigm and we've got the new paradigm. So the old paradigm, pain is purely structural or mechanical. That's what we always used to think. Pain is recognized in terms of the site of pain, and the doctor or medical practitioner may say to you, where is the pain? Chronic pain treatment is mostly painkillers, and there's concern around that with addiction. Chronic pain is managed at best. That is a notion that has gathered speed recently, and that's on the back of CBT, cognitive behavioral therapy. And the premise behind CBT is that a patient learns to cope with the pain, not that the pain is addressed. So chronic pain, that's pain over 3 months, is treated as acute pain in the old paradigm. What we're interested today in is in the new paradigm. That's resolving chronic pain. So we then look at chronic pain and see that it's got many variants. It's not just the site of pain on the body. Chronic pain has a central component. That's the brain, the mind, the psyche makes a difference. And yes, people take painkillers, and those painkillers have an effect that we need to recognize on hormone regulation, on personality, and on energy long term. So chronic pain can be treated sometimes even to the point where it is resolved and not just managed. So a lot of the people that I work with don't have pain anymore. So some people, and it is amazing, can have had pain for 25 years, and extraordinarily within 2 weeks of doing this work, I'm thinking of a particular woman who was a lecturer at Galway University, she had no pain, none, after 2 weeks, which is staggering to me. I'd still check in with her, and she thinks it's really funny that I'm still checking that she has no pain, but she has no pain. So chronic pain is treated as a distinct condition and as very different to acute pain.
Now, can I just come in there, Max, because this is really interesting. And I'm seeing parallels here with chronic and acute injury, whereas the chronic injury is the unresolved problems that just linger in the background, and the acute injury is something that happens, a sprain, a break, something like that. Could we think of that in a similar sort of two paradigms there?
Yes, absolutely, we could. Yeah, very good question. Yes, we could. Okay, so it's good that we're going to have a session of questions later, because I'm sure everybody has got some questions, and please do write them down so that we can actually come back to them, because I'm aware that what I'm going to be going through today is a lot of information, and depending on your perspective and your cultural understanding of pain, it would be wonderful for us to share some of those questions and to understand this a little bit deeper. So disorders that are likely to benefit from the resolving chronic pain approach are anything to do with the back pain. To my mind, it's kind of taken the place of ulcers. And Dr. John Sarno, who was a pioneer of this work, referred to men in New York City in the 1970s. The image is coming, isn't it? We can just see this, of all having stomach ulcers. And the pharmaceutical companies treated the ulcers. So once there was medication for it, where did the pain that had been about the brain having some issues go to? Well, it went to the back, because it couldn't go and manifest itself as a stomach ulcer anymore, because there was medication for that. So there's never been a absolutely guaranteed cure for back pain. It's the one thing that there's books and books about, like unexplained pain in the back. And the reason for that is what I'm hoping to explain today. So neck pain, joint pain, tension headache, repetitive strain injury, very common for dancers, abdominal and pelvic pain, that's IBS, the pregnancy-related pelvic girdle pain, which I was talking about earlier, and exhaustive conditions, so fibromyalgia and ME. And again, anyone who's had any brushes with fibromyalgia or ME will know the absolute frustration that someone experiencing that diagnosis will have, because literally there isn't enough known about it. And what our research has sort of come up with is that it is PPD, it is TMS, it's about the autonomic nervous system, and that is gradually being taken on board. So limitations and clinical caveats to this approach. This is a really important piece. So chronic pain, as I've said, laboured almost, is over 3 months. And always we check for structural injury. So TMS practitioners work alongside traditional medicine. The idea is that it's an integration. So it's important for people to check that there isn't anything obvious wrong. So where TMS comes in is when someone has been told time and time again they can't find anything wrong. So one of the things that's a real indicator that it could be TMS is, does the pain move around? So as dancers, we know that pain can move around, and that therefore indicates it's not structural. Is the pain inconsistent? So is it high at one point and have you forgotten about it at another point? So if it moves from one place to the other, which is what we talked about earlier, that's a dead cert that it is TMS. And also, this is a peculiar one, and people are often just blown away by this. Does the pain rage at night? And if it does, that means the unconscious mind is desperately trying to protect you against something. And that's TMS. Okay, so.
Can you, Mags, just explain to us again what TMS stands for?
It's tension myoneural syndrome.
Great, thank you.
And PPD, which is the more modern acronym, is psychophysiologic disorders. And so that's quite off-putting because it's hard to say. When we do an audiobook, I'm going to have to do the audiobook because apparently of the 4 editors, I'm the only one that can really say it. So why you chose it, I don't know. But anyway, there you go. That's not my decision. It's been made. It's psychophysiologic disorders.
And am I right, Mag? Sorry to interrupt again. We've been looking within the dance pedagogy, but also within the preventative dance medicine course about taking a biopsychosocial approach to our work as a practitioner. Now, I think that this is fitting very nicely with Engel's model of the biopsychosocial. Would that be correct?
Yes, it is. This takes it a step further. It's like there's another turn of the wheel, but that body of work set a foundation, if you like, for this. Yeah. So one of the chapters in the psychophysiologic disorders textbook is a history chapter, which I wrote because I have this huge interest in history. And also I just feel that even though not every medic is going to read that, and the textbook is available for anyone, we've tried to make it so that it's layman terms, so that it isn't Latin for a start. But the point is that starting place, that history, it gives us a foundation, so it's a context for us to understand. And that whole integration of body and mind means that if the mind is not present when you are, for example, doing contact improvisation, that's not going to end well. So we know as dancers, we're light years ahead in some ways. We know about the body and mind and that integration and how important it is. And so the biosocial,
biopsychosocial, yes, BSP.
I might be able to say psychophysiologic, but I can't say that. Right. So yeah, that is a tremendous premise for this work. So you're right.
Thank you, Max.
Good question. Okay, so how neural pathways can cause pain and other physical symptoms. The starting point is the autonomic nervous system. So the autonomic nervous system is made up of 3 modes of operation. One is to do with the gut, and that has nothing to do with what we're going to talk about today. So I've just left it out, but I'm acknowledging that there is a third one. So the sympathetic nervous system, that is called the stress response in layman's terms. So cortisol and adrenaline course through the body. Those hormones produce action and energy. So if you're watching a very fast-paced piece of dance where there are lifts and there are catches, the adrenaline has to be on in every dancer that's involved. Then there's the parasympathetic nervous system, and the hormones that then come into the body, they encourage rest and repair. So I refer to them as the healing hormones. And the difficulty for us is that we might lean towards the stress response, and we're not allowing the repairing to come in as much as it needs to. So that injury that was an acute injury isn't getting the opportunity to heal because the healing hormones aren't getting access to it because the body's in the stress response. So that two-way interchange from body to brain and brain to body is necessary for the body to heal naturally. That doesn't mean that we say no to whatever medical intervention we want to have as well, but we want the internal systems of the body to be ripe to respond to whatever intervention we've deemed to be important for us with respect to whatever injury it is. So that means the healing hormones need to come into the system. And if the body is stuck in the stress response, they can't come in. It's an on-off switch. It's not a sliding scale, which took me a while to really appreciate. So if you've got your phone on and you're going to bed, then you've got a grumbling stress response actually happening. And that means you can't switch into the rest and repair. I hope that sort of makes that clear. Okay. So as you can see, patients get stuck in a neural loop of pain, of fear, anxiety, frustration. And the unconscious mind recognizes that the person is stuck in that loop. And the only way they can communicate to protect that person is to create pain. And that's the pain that we might experience over 3 months.